Hello, everyone. Thanks so much for joining us today as we await for all participants to join us. Please find both closed captioning at the bottom of your Zoom screen, as well as translation services. We will have translation for today's webinar available in Spanish and in Cantonese. And instructions are here to find those translation services either on a desktop or on your iPhone. So welcome again as we wait for all participants to join. We're really grateful for you joining today. Please find both closed captioning and translation services at the bottom of your Zoom screen. We will have translation today in both Spanish and in Cantonese. We still have participants joining. So while we await all of our participants, we hope to maximize time for Q&A after our panelists have shared their content. So please submit questions using the Q&A function, also found at the bottom of your screen. We will give just 30 more seconds for all of our participants to log on. But thank you for joining, and please make use of the captioning service or the Spanish and Cantonese interpretation. Wonderful. Before we start, we want to acknowledge that UCSF is located on the unceded ancestral homeland of the Ramaytush Ohlone people, who are the original inhabitants of the San Francisco Peninsula. We also acknowledge those Jewish members of our community who are marking Rosh Hashanah today. The recording of this webinar will be available in the coming days on YouTube, as well as on the UCSF CARES website. So without further ado, I'm thrilled to introduce Mr. Matthew Cook, President of Benioff Children's Hospitals.
Thank you, Liz. It's a pleasure to be here this afternoon with all of you. This is a very important topic on variants in school, and I think it's one that we're all monitoring closely and very interested in. As Liz mentioned, I'm the president of the Benioff Children's Hospitals. For those of you who don't know me, I started earlier this year in end of December, beginning of January, so right in the middle of the pandemic. And I know we wished it were further along at this point. I think when the summer started, we thought we were going to be in a different place, but here we are. And so UCSF CARES, for those of you who are not as familiar with it, it's the collaborative to advise on reopening education safely. It started with a group of pediatricians who identified the need to have one unified voice as healthcare professionals with our education partners in the school districts, really with the intent to provide data and data interpretation as our education partners contemplated remote and in-person learning models early in the pandemic. Since those early days, the group has now grown to well over 100 UCSF affiliated healthcare providers across the various UCSF schools and departments. And they've volunteered their time and expertise and created a wide-reaching 6-part webinar series that has been viewed more than 14,000 times at this point. This group has also drafted guidance on in-person and remote learning, provided counsel to local, state, and federal policymakers. The group has served, members of the group have served on the Department of Public Health task forces, and really just have given countless hours to local education partners, schools, and school districts to craft and implement policies to pave the way for in-person learning. Through CARES, we've made 2 formal partnerships with local school districts. We have the Benioff Children's Hospital Oakland Unified School District Task Force, and we also have the UCSF San Francisco Unified School District Partnership. And so in that context, we have UCSF faculty providing expert guidance to both of those unified school districts to support their efforts to return to in-person learning. So without further ado, we're going to move right into the agenda, and it's my pleasure to introduce Dr. Ted Ruel, who's the professor and division chief of pediatric infectious diseases and global health for UCSF. And Ted, please take it away.
Thank you, Dr. Cook. Yes, it is my pleasure to start us off. And I was asked to begin with kind of an overview of the clinical and epidemiology of COVID-19, an update for now, and of course, a focus on the Delta variant. So we'll do this for about 10, 15 minutes here. And we'll jump right in. So first, I'm sure people have been reading a lot about the Delta variant, but I'll just quickly give some background of introduction about what it represents. So SARS-CoV-2, like many viruses and many coronaviruses, is constantly evolving. And like viruses, they basically mutate, and when one is more successful at filling a niche, it expands into it. And that has been a lesson taught very clearly to us about the Delta variant. You may have seen it referred to, at least originally, by its more kind of virologic name or acronym with the B16172, they are named, of course, by Greek letters now as they become of interest to the community, and this has become known as the Delta. It was first identified in India in December of 2020 and really rapidly spread across the globe into countries, quickly taking over and spreading among its population. On the right, you can see a graph that breaks up by month the different variants in circulation. Alpha, you can see as the kind of royal blue here, and then the orange color will be that of the Delta variant. And then probably hard to see, but the far left column is the end of May, and the far right is August. And you can see basically that very quickly over the course of these 3 months, Delta has completely taken over with over 98% in the USA. It is twice as transmissible as the original Wuhan variant and 1.5 times as transmissible as the Alpha and Blue. So it just basically is that much more easily spread, and so has come kind of quickly through the population. We're still studying why this has been so efficient, but we have learned more. There are some key mutations. I mean, it's not a huge virus, but mutations in the right place of its binding receptors increase its binding affinity, so sticking to cells, its ability to enter cells, and also some about impairing our ability to clear it. So those things together have led to this spread across the US and to the recent surge that we've seen across the US now. So let's look more closely at that surge. This is a graph from the CDC that shows it's the most recent surge starting in April. This is the past kind of year and more, starting last April. You can see the big winter surge that we all, of course, will remember in the center. And then over on the right, you can see the most recent surge, which has been very strongly dominated by Delta. And so the first thing to note is that this surge is big, but not quite as big yet as the surge in the winter. But the second real important signal here is this is the first you'll see where we really see a difference in pediatric numbers. And so these are not total cases. This is the rate per 100,000. But you can see now that the kind of mustard yellow color curves, which represent the younger age groups, used to be well below the incidence of the older age groups, but now they're at and even beginning to exceed in some cases that of older adults. So we'll talk more about this. This is primarily driven by the fact that a lot of the older groups have now gotten vaccinated, of course, and our younger kids haven't, but it's an impressive change in pattern, and we're seeing the increased incidence in children that we have heard about in the news and may have seen or heard about from friends and family. So this is just another look at these data, but just looking at the children, you can see that our peak now is at the winter levels. So for us, this is as big as it ever was, and in many parts of the country, much higher. You can also note that the steepness of the curve is impressive, that over really this month from July into August, it's the end of August, real dramatic increase in case numbers across, this is now cumulative across the whole country. These are cases added in the prior week. Again, taking the whole country in one look. This just goes back to the pattern I wanted to highlight again, that this impression that we've had that it's more kids is really right on. At the beginning, the case numbers in children represented only 2%, and now they're over a quarter. This is 22%, but even close to a quarter now with more recent numbers of what we're seeing across the United States. Okay, so this might be the first kind of head scratcher. Like for the whole earliest part of this pandemic, we were all frankly surprised by how little disease we saw in children. There were some ideas of, well, they might be a little more resistant to infection because of the receptors in their nose and such, but it still remained a mystery to us how surprisingly low these numbers were. But now, of course, we're seeing those numbers. And so a big reasonable question is why? The first big explanation is that Delta is just simply more transmissible. And it's more transmissible to everybody, but people that are vaccinated, it's not true. So we have a whole bunch of kids that are vulnerable to a more transmissible version of the virus. And the second is we've really returned, of course, as everyone has enjoyed, to more social norms with more interactions in camps and schools and socially. And of course, kids going with their parents who are vaccinated are enjoying more liberal activity. And so a lot of that combined basically is just more children being infected. And of course, our impression of this is exacerbated by the fact that we're seeing relatively less disease in adults, particularly in California, all adding to this impression. So how do people get Delta infections? Like, where are these occurring? Well, I'm not going to talk a lot about this, but I thought this was an important story to tell. These are data from the UK, where they experienced a Delta surge earlier than we have. And what I want to highlight on this slide are the differences between where these infections are occurring. So the dotted lines are infections that occur outside of the house, and the solid lines are those that are occurring in the home. And the purple are the Delta strain story, and the alpha are in the pink. And so you can see the two pink lines run relatively close, and especially towards July, they're very close to each other, but a lot of overlap, which is to say you're just as likely to get an alpha variant from home as you are outside the home. But this is, of course, to highlight the big difference we see with Delta, which is to say many more infections occurring from household members than outside household members. And I think this just really again speaks to, if it gets into the home, it will often spread quickly through the home because of its increased transmissibility. Okay, so now I want to look, instead of just case numbers, what are we seeing in the hospital with children? And unfortunately, we have seen a really significant peak, and again, one that is now rivaling. This is a little bit behind, you will see. These are data that were published just last Friday in the MMWR, tracking hospitalizations nationwide, but you can see the numbers were just climbing there mid-August when they did this analysis, and now they're pretty much up there to the winter surge. So we are seeing as many kids as ever, and in many areas more than before, children hospitalized. So this is, of course, something we are not happy to see, but tracking the outbreak and underscores, again, the importance of vaccination and getting it to children, even the young ones, that as soon as we get the safety data and they become eligible. This point about vaccination is underscored by a couple patterns relative to this. So first, among the adolescents, we have much higher rates of hospitalization, 10 times higher, among those that are unvaccinated and vaccinated. And without going into details, this is also what we've seen locally. Unfortunately, a lot of the children that are admitted from homes where there aren't high vaccination rates and that they themselves haven't been vaccinated. And the second thing is that the pattern of hospitalizations and ED visits across the country are also increased in states with low vaccine coverage. So again, scoring that when you have a community that's vaccinated, you're going to have fewer hospitalizations and incidents in children. So one important question we've been watching to see, is Delta just more spreadable and more transmissible, or does it cause more serious disease in children? So the metaphor you often hear is, of course, the tip of the iceberg in children has always been smaller, which is to say, when children get infected, it's a smaller portion that gets sick. So are we just seeing more sick kids because we're seeing more infections, or are they sicker? And on the same kind of batch of publications last Friday from the CDC, there's a hint at this. And the way to read this is again hospitalization rates across the last year from August to August. You see the peak in the winter and the peak now, and about the same. But if you look at the black lines there, you'll see these are the proportion of kids in the solid line that are admitted to intensive care units, and the proportion that require mechanical ventilation. And what you'll see here is those lines are basically flat, which is to say through the winter and to now, we really haven't seen sicker kids. The kids being admitted aren't necessarily sicker, they're just increased in number. So not a big signal for more severe disease in children. That said, we need to keep monitoring this. This is really just the first look at this from a high level. And we do now, unfortunately, know that the Delta does seem to cause more severe disease in adults. So we need to keep monitoring this situation in children. Okay, so I'm just going to end with some closer look at the epidemiology in California. In California, you'll see we have the highest case numbers by state across the country, which could at first glance be alarming, but we have the largest number of children and a huge population. So this is not surprising by overall rates. And then on the right, you'll see a panel. This was actually published in the LA Times, where they pulled data from the CDC that showed that this is overall kind of population rate of hospitalizations in children was much higher in places like Texas and Florida compared to California. So this is a kind of a consoling sign that we may, on a population level, still be doing better for our children compared to other states. But I wanted to show some data to look a little more closely at this. So this is a busy slide that compares data from California and Florida. California is on the top panel of figures, and Florida on the bottom. And so first, please look at the figures on the right. So you'll first see that in California, we had a big winter surge, and then now this is across all ages. Our surge in July is much more blunted. And so this really, again, is a testament to good fortune and high vaccination rates and practices here that we've had a blunted second surge in California. Whereas in Florida, you can see the second surge now is even just as high. On the left, you can see a closer look at pediatrics, where in California, it's about the same, but in Florida, their pediatric surge now is much higher. So what underlies these differences? So the first thing you'd say is we spend all this time saying how great vaccinations are. Well, actually, Florida's not that far behind us in overall vaccine coverage. So it's not simply a vaccination story here. It's probably other things which underlie this. And other, one important difference is in behavior, where mask mandates are, of course, banned in Florida, whereas we've had much more kind of proactive in terms of getting ahead of the curve and more restrictive in terms of social interactions and masking, both in terms of uptake, putting aside even mandates. So I think it underscores that vaccination is powerful. We also need to remember the great success we've had in California as a benefit from the other interventions we've done. But I want to end with some good news, which is this Delta surge has certainly plateaued and may well be ending. These are data I pulled just updated today. Overall in the US on the left, you can see that curve beginning to turn nationally, but we are even further ahead of that in California, where the curve is both smaller than the winter surges I've mentioned and pretty clearly heading down now. So this is a great sign that we're going to have to keep watching. This is a closer look, and I want to acknowledge that the California Department of Public Health for these age stratified data, but you can see here that specifically among children, you can see the pink line is the 0 to 17-year-old children. That curve is also specifically bending, in addition to the overall curves for older adults there too. And then even locally. So these are data updated today from Alameda County. You can see the curve bending over. I included one adult curve in mustard, but the pediatric curves are the others in blue, purple, orange, and blue again. Again, curving down, great news. And then in San Francisco, it's a little bit delayed, and it's not quite as pretty of a graph, but also a curve going down in San Francisco. So great news that we may be exiting this surge that is Delta driven. Before I wrap up with some closing comments, I did want to highlight real important ethnic disparities that we continue to see in COVID-19. This has been an unfortunate signal throughout this pandemic that I think has rightly been pointed out because it is across the United States and even affects us here in California. So these are data from California, and it's one of these figures I want to make sure I explain well kind of what it represents. So these are all rates compared to people to kind of rates among whites. So this is Native American, Native Hawaiian and Pacific Islander, multi-ethnic, Latinx, Asian, American Indian or Alaskan Native, or African American. And these are rates by color as the age group, and anything to the right of the dotted line means you are at a greater risk than the same age group in white populations. And you can see, putting even just kind of like not looking at the colors, a significant portion are over 1. But I want to highlight the fact that if you look now just at the color of the mustard yellow, this means for children 0 to 17, the differences are even more dramatic. So the ethnic disparity we have seen across populations really dramatically affects children, continued through this recent surge into August of 2021. Okay, so I want to leave with some take-home lessons around the epidemiology and clinical disease that we're seeing of COVID-19 in children. And then I'll hand on to our next speaker to speak more specifically about schools. So we know that Delta is highly transmissible and moves into susceptible populations, which is what we've seen. Current vaccines, although slightly impaired, remain very effective. And we have a lot of evidence from this from multiple cohorts around the world. They vary somewhere in their numbers, but even partially effective overall, when it's generalized across the population, can lead to big effects that we've seen and we've enjoyed the benefits from in California. The Bay Area and California has again been more fortunate than the US because of our combined efforts. And we have ground for caution that we may be exiting this current surge just in time for schools opening and entering into the fall season here. And just a few comments on how I thought it would be advice for people to think about as we face, again, this kind of recent surge with Delta, new variants in schools. I think, this has been, again, it's become silly to talk about how this pandemic has demanded kind of patience and resilience among us, but we need to keep it up and to begin to enjoy the situation we have in California. Unfortunately, COVID has never been a disease of black and white rules, simple stories, and oh, this works and that doesn't. It's always been, oh, this works a little bit in these circumstances, a lot of nuance, which is really hard for people to make decisions around and hard for public health and school entities to make clear guidance about. And it's been constantly changing. So I beg people's faith with this. It's hard to navigate a lot, but we need to keep it up to be able to keep schools open into the fall. The same preventative measures seem to work with with Delta variant, even if it's more transmissible, so stick with it. And optimizing those will be different though for each scenario. Different schools, different settings, we'll be able to emphasize different elements of it. So work with what's being developed in your communities. Following the rules and the guidelines that set out together as a community is the only way we're going to keep things going. And again, just a plug to advocate for vaccination. It's been really hard to get over that final hurdle, but I think the strongest messages now come from people reaching out to friends and families to help get the last groups in. So I will wrap up there. And it will be my pleasure to stop sharing my screen and hand over the presentation to Naomi Bardach. I imagine Naomi is known to many because she's played a big role in the pandemic response, both in the Bay Area and more recently in the state. She is now recently promoted to the rightful rank of professor in the Department of Pediatrics and also of Health Policy. She's vice chair of Health Services, and she's been a leader with the Safe Schools for All team on a state level. So we're really lucky to have her speak to us today.
Thank you so much, Dr. Ruel. And my internet just gave me a sign that it's unstable, which hopefully will not persist because it normally is not unstable, but just to give you guys a advance apology if that happens. And I'm going to start my slideshow. Hold on 1 second. And thank you guys so much for inviting me to come back and be part of the CARES webinar. It's always such a wonderful community and such an important thing that we all are doing together. So and just to clarify, I wear the Safe Schools for All team hat, which is working for the California Health and Human Services Agency, which I've been doing since December, helping to figure out how do we use an evidence-based approach to do schools safely and successfully in California. And I always do some acknowledgements, which is very similar to what Dr. Ruel was just saying, which is that we are always learning more. We watch the data very carefully, and the focus is on using evidence to achieve those twin goals of safe schools, but also successful schools, successful in-person learning. We know it's so important, and the goal is to do it safely. So understanding how can we use our evidence to support that. And I also wanted to acknowledge Dr. Sohail Sood, who contributed substantially to the slides today that I'll be sharing. He is a subject matter expert who has also joined the Safe Schools team. He's an associate professor of pediatrics at UCSF, and he's the co-lead of the California Safe Schools for All team. So just to put this into a little bit of context, so sort of the goal for me to talk today is to talk more deeply or more specifically about how do we do safe schools. So just to give some context as we think about it, the school year is starting for many students, but here's a preliminary snapshot of basically how are things going so far. The good news in California is that we haven't seen any delays due to COVID-19. So there are some schools in other states that have started the year in distance learning or delayed their start dates, but California schools appear to have started according to schedule. 20 of the 20 largest districts in the state have opened and are, teaching students in person now. Also, California school closures have been minimal. So some schools like SFUSD have been open since the middle of August, and we have not been seeing very many school closures. This is a map by a group called Burbio, which is actually a very great resource that shows school closures around the country. You can see a lot of school closures, mostly due to outbreaks in other parts of the country and very few in California. And it's because nationally and in California, schools are struggling to manage the variant, right? It's this new, we're in a surge, we're trying to figure out how to deal with the variant. But although schools in other states are closing for the in-person instruction due to outbreaks, closures in California have been relatively minimal to date. And the only small update on that is that there are some schools more in the northern counties that are having closures, mostly due to staffing shortages. They have lower rates of vaccination and lower mask adherence actually in their schools in general. And so those are the schools that are having some closures that you might be hearing about in the news. And that's kind of the context in which those are happening. As we continue to talk and think about safe schools, I think it's always helpful to kind of level set and share what is the conceptual model of spread from schools. How do we even think about how we do schools safely? And so I go over this sort of model. Step one, in order for there to be spread, you have to have virus in the community. So that's step one. Then step two, the virus has to come onto school campus. Step three, there's transmission in school where the virus transmits from one person to another. Somebody gets infected on school campus. And then step four is that it would go out of the school and somebody would get exposed or infected outside of the school context. So that's kind of how it would spread either and affect either people in the school or potentially the community outside of the school, family members at home, et cetera. So what are the layers that we use in those 4 steps? We know that step 1 and step 4, those vaccines are incredibly effective at helping to decrease the amount of virus in our community and decrease the risk to people outside of the school setting, that out of school transmission. Then step 2, how do we prevent virus from coming onto a school campus? If the case rates are high, testing is actually very helpful in being able to identify those cases before they walk onto school campus. And the other really key piece that we're learning about now, the stay home when sick piece, we're hearing cases, both adults and sometimes students who come on with very minimal, they come onto campus with minimal symptoms. They think it's allergies, it's just a runny nose. And then sometimes it turns into a COVID infection. It turns out that it's a COVID infection. So people staying home when sick and getting tested is an important piece to prevent the virus from coming onto the school campus. And then we know, of course, in-school transmission, masks are very effective, a very straightforward intervention that we can use, and ventilation, which allows the indoor space to become more like the outdoor space in terms of the air has less of an ability because it's being exchanged frequently, then the virus is less likely to transmit from one person to another. So what does the picture look like of those key safety layers? People talk about the Swiss cheese model. So as Dr. Ruel was referring to, each layer might have a hole or two. Each layer, there's not one layer that just stops everything. So, but we use all of these layers together. If you take the layers of Swiss cheese and you change their orientation a little bit, then those holes, there might be a hole in one slice, but it gets blocked in the next slice. And in that way, using these key layers, we can create a safe school environment. So just to highlight, the layers are all 12 plus, and all people 12 and older in school are vaccinated, and in the outside community, which is what we were talking that last slide. Testing and stay home when you're sick, masking indoors and that hand hygiene, improving the indoor air quality, and do outdoor teaching when possible and outdoor activities. So I'm going to move into a couple recent studies that have come out, because it's always helpful for us to talk about what have we just recently seen in the literature and what have you heard about recently to help explain some of the evidence that we're seeing and how does it affect our thinking about schools. So there was an outbreak in Marin County that was in a Marin County school that was Delta associated. That was in May 2021. This study just came out, and this is the figure from the study, which shows it was a teacher. This index case was the teacher, and this is a teacher who wasn't vaccinated and who came to school and read out loud to her second grade classroom with her mask off. And she was symptomatic when she came to school. Very similar story to what I just said. Very mild symptoms, thought it was allergies, and was in school for a couple of days, May 19th until May 21st, Wednesday until Friday. Friday, she had a fever and got tested. Actually, I don't know if it's what the gender is. So the teacher got tested on Friday. And you can see that the first row got infected, all of them. And then the second row had 3 people. And the third and fourth rows had 1 person positive, and then the 5th row had 2. So you can see that without those masks, with those symptoms, that there is some very clear spread that can happen in schools. And it's particularly, this is what can happen in Delta. This study, there's another figure from this, which basically shows the picture of this is the index case, and these are the second grade students in the blues, and then there was some transmission at home. And then there's another cluster that happened in the same school in the 5th grade class. They don't really actually know exactly how it started, but it was associated with a sleepover event that happened on day 2 of the exposure. That is another important sort of take-home point from this study. So there's a couple key things that got highlighted. One, the Marin Department of Public Health mentioned, sort of reflected on the fact that, this outbreak sort of stopped here. There wasn't more spread out into the community, partly because there were so many good vaccinations in place. They actually had a very high rate of vaccination in the community, even as early as May. And the other important piece is that we know that much of our school associated cases, meaning that cases that we find in schools, are sometimes going to be very much associated with these sleepover events, things that are happening outside of the school. And the last sort of thing to share with the group is that as we were developing and discussing leadership discussions about schools guidance, we had actually heard from the Department of Public Health in Marin about this outbreak, and it informed our guidance as early as July when that guidance came out. The indoor masking, the emphasis on masking actually is reflective of this study. So as we think about how to do schools safely, this is actually part of the data. The Delta data was informing the guidance that supports our safe schools now. The other data that came out shortly after that, or that happened shortly after, it was the data came out in July also, was about an outbreak in Barnstable County in Massachusetts. You might have heard about it. This came up in several times in the newspapers. And there were a couple findings from the outbreak. So it was an outbreak also of Delta, and they found that they had similar what's called CT values, also known as viral loads, which is how much virus you have in your nose or in your respiratory tract. For both vaccinated and unvaccinated people, it turned out it was very similar. So 21.9 versus 21.2 in that study. And they also found that vaccinated individuals can spread the Delta variant. So the implication from that study is that it informed the guidance. The CDC, when this study came out, basically at the same time, the CDC changed their guidance to say, you know what, we should do universal indoor masking in K through 12. And more broadly, they were recommending masking for vaccinated people indoors or crowded outdoor venues if there was an area of substantial or high transmission. The other thing they found from that outbreak, though, in that study is that the vaccine continues to hold up exceedingly well at what matters, which is preventing hospitalization and death. So the risk of severe disease or death is reduced tenfold or greater in the vaccinated. This is what Dr. Ruel was saying is also been shown to be true for adolescents. This was the demonstration in adults. And risk of infection also, even just getting infected, was reduced threefold in the vaccinated population. Very few people were hospitalized in the outbreak. And the implication is that it could have been a much worse outbreak if it were not for the vaccine, which reinforces, again, the importance of getting vaccinated. And the last more recent study about Delta variant, which I think is also helpful as we continue to think about schools, is that it's a preprint study, meaning that it's a study that's been published but not peer reviewed yet. From Singapore, it showed similar CT values, which again is that thing about viral load. How much do we have actually in our nose or in our respiratory, in our airways? That the viral load in vaccinated and unvaccinated people they're similar at the start of the infection, but the viral loads drop more rapidly in the vaccinated group, which means that their amount of virus they have that they might share with somebody goes down faster than if you're unvaccinated. So that means that vaccinated individuals might be able to spread COVID-19. That's what we saw in the Barnstable outbreak, but they clear their infection faster, and therefore they're probably going to spread less than unvaccinated individuals because they're only going to be spreading for a much shorter period of time. And then finally, the last piece of data to just highlight very specifically around schools is data from North Carolina from March to June 2021. So Delta was already in their community. It was not as high. There were not as many Delta cases as there are now nationwide, but this data can inform our understanding of how Delta might work. And they looked at 100 districts, 14 charter schools, 860,000 students of K through 12, and 160,000 staff under what was called in North Carolina at the time Plan A, which was masks were required. There was no minimum physical distancing. So you might remember, right, there was a 3-foot minimum physical distancing recommendation. They, at that time in North Carolina, said, we're not going to do minimum physical distancing. We can't get all of our students in. And they did full capacity bus seating, which is another big deal. It's going to be less relevant oftentimes for San Francisco schools, but there are many schools around the country that are trying to figure out how we bus our kids back and forth. They had a very low secondary attack rate, meaning very low amounts of in-school transmission. Less than 1% of cases that were on the school campus went on to have another infection. It was 1 in 3,000 people that actually happened, 3,000 students or staff, which is way lower than what was happening in the community at the time. The other thing they found is that athletics appeared to have a higher rate of transmission, which is what we've generally been hearing throughout the pandemic. And then finally, this was data reviewed not just by North Carolina, and not just by Duke, which is actually the university investigators at Duke University, a pediatrician actually was looking at that data, but it was actually a collaborative, a multi-institution academic consortium around the country, 13 different academic institutions looking at this data and sort of interpreting it to say, masks are key. There is no need for a minimum physical distancing requirement, and recommending that people can do full capacity bus seating. And lastly, I always find it's really helpful to help people understand. We hear headlines all the time in the news, and it's helpful to share some ideas of how do you interpret those headlines that can sometimes feel very scary. And I like to share and support people with understanding how we read them, how as a scientist and as somebody who's always thinking about schools, how do I read the headlines in order to understand what does it mean about schools? What's the implications for schools? So the first headline is LAUSD reports 3,255 students who have back to school COVID cases. Well, it turns out the context of that, if you read deeper in the article, is that over 350,000 tests were conducted. So the overall rate of how many people actually had COVID was 0.8%. That's like a test positivity of 0.8%. That's very low. And the good news and the important reason why testing can be very helpful is that the cases were identified before they entered the classroom. So the takeaway point is that as a testing hub and as schools, they may detect many cases in children without there being in-school transmission, right? That's what we want to prevent, that in-school transmission. School-associated cases that are getting identified are often a sign that the school is screening out COVID-19. And then the last one is check the denominator, meaning like look at look at how many tests were actually being done so that this number gets put into context a little bit more and feels less scary. The next one is the Delta variant more dangerous for children? That's the headline. A growing number of kids are very sick. So you saw Dr. Ruel's slides, and I think it's helpful. The context there is we are in a nationwide surge, which means both adults and kids are getting more COVID. The COVID patients right now are generally younger because the at-risk adults are vaccinated. So that's good news, important that those adults are being vaccinated. We know that those higher pediatric cases are happening in places with low vaccination rates often, and where mask requirements are not allowed. So that's true for Texas, that's true for Florida, that's true for Arkansas. And it's a really important thing to remember that California is different both in our vaccinations and in our approach to mask requirements in the indoor setting for K-12 schools. And so the takeaways are that Delta's transmissibility means that there will be more cases of all types. Delta primarily impacts the unvaccinated, and we know that children do make up a greater portion of the unvaccinated population, but that vaccinations as a wraparound layer and masks are really key, and that the policies we have in California are creating some safety. And then the last one is the Bay Area schools face coronavirus cases and quarantines, and that parents are feeling overwhelmed. And the context for that is that, as you guys are probably familiar, that schools are identifying cases. They're conducting contact tracing. They're sending notifications to families. And the takeaway to that is that schools are creating safe spaces through these layered approaches. Those same cases are being encountered in stores, restaurants, other public places, but not necessarily being identified. And so the difference is that schools have those safety measures in place, including the testing and the contact tracing. And then some early lessons learned we've gotten so far from schools. Pattern number one, school-associated cases are caused by non-school social events. I already mentioned some of these stories. Pattern number two is that cases are caused by symptomatic individuals who went to school while sick. Highlighting, we've heard it not just in schools, but also in healthcare. I think it's just my allergies that seems to be a very common story. So anybody who thinks they might just be having allergies or their kid might be having allergies, please go get tested before your kid goes to school. And then pattern number three, schools are adjusting to those modified quarantine practices. So modified quarantine is basically a way of allowing students to stay in school if they've been exposed, as long as they both parties were wearing a mask and as long as there's some testing going on for that person who's staying in school. This is a new practice. It's something that the CDC, sort of allowed for in their guidance, and California is doing a somewhat adapted version of it. And a lot of schools are just trying to figure out how to do it. It's new, and so for any one of these new things, it takes a little bit of learning, and so that's part of what's happening right now. People are sharing resources right now, which is terrific. We have to have a collaborative approach to this. And then the testing resources from the state is really supporting these efforts as well. There are people who are having staffing shortages caused by low rates of vaccination. So everybody, this is more for those northern counties than San Francisco, but vaccinate, vaccinate, vaccinate. Adults, students are eligible, really important. And then there's some difficulty ramping up testing capacity at sufficient speed. Some schools were looking way down the road in June and July, and then some schools are all of a sudden like, oh my God, Delta arrived, and I wasn't really ready yet. So the schools that have been preparing earlier, they have their testing programs set up. Other schools are really trying to get their testing set up as quickly as possible. And that's just I think it's important to say that's really important and people are doing the right thing, but there is just some startup time that is required. So the state is doing a lot of support, providing no-cost testing. And then also in the lower part of the slide here, there's strike teams that are being deployed to schools who are having an outbreak. If a school doesn't already have a testing program set up, then the state has strike teams that can go out and help with a lot of testing, and then also offer vaccines to anybody who wants to get the vaccine, because often an outbreak will sort of trigger people to be like, oh my God, maybe I should get vaccinated. So both of those things are what the state is able to send out, in addition to providing this ongoing no-cost testing. And then I'll just end with pointing people out to the schools hub and a parent page with lots of information from the California Department of Public Health for technical assistance for school administrators and local health departments here for if anybody needs to put in a technical assistance request, and lots of information for parents as well. So encouraging people to go there. And I think I'll stop there. Thank you guys so much. Oh, sure. And now, sorry, I will introduce Dr. Daniel Woolridge, who is a fantastic clinical fellow at in the Department of Pediatrics, meaning that he does a lot of work helping out with taking care of children in the pediatric clinic, as well as he's the program manager for the UCSF SFUSD partnership. He plays a really key role as a liaison in that partnership. And so he's going to talk to us a little bit more about sort of what's going on locally in the local context. Dr. Woolridge, if you're ready to share.
Absolutely. Thank you so much, Dr. Bardach. I'm just going to share my screen very quickly with everyone. And because I want to get to the questions, as I'm sure many of you all who are attending this want to, I just have this slide. I am, as Dr. Bardach mentioned, the program manager for the partnership between UCSF, and specifically I'm managing the SFUSD partnership. As President Cook already mentioned, there is a separate team who is working with Oakland Unified, but we are talking regularly. And before I get to questions, just 3 quick things that I wanted to summarize from what has already been said. And it's key take-home things I want people to take away. And it's that districts have been tirelessly working to get this done and to get your kids back to school, and particularly back to school safely, just the entire time. And so I cannot underscore the point enough that your school districts and staff have been working very hard to make this as safe as possible for your children. And point number 2 is that, as Dr. Bardach mentioned, in terms of when a lot of the data, particularly around Delta and Marin County, particularly in that school that we all heard about not too long ago, that data was made available before guidelines for opening schools was made available. And there was considerable lag time between the data that informed safe school guidelines and the data that informed the news. So I also want to say that there may be a bit of a gap. And then the last one is that collaboration is the key to all of us. We're all a shared community and we all want to make sure we're keeping each other safe. So with that, I'll definitely transition over to questions.
Thanks so much to our panelists. I'll ask all of you to turn your videos on so we can see your faces as we ask some questions from the audience. So I think, Dr. Ruel, if you can come online, perfect. I'd love to start with you. There are a lot of questions about different types of tests, including home tests. So this is a multi-part question, but if you can distill it down, should schools accept like a self-report negative home antigen test after they have symptoms or an exposure? Do we require a molecular test? And then there are a lot of questions around what's the appropriate timing for those specific types of PCR/molecular versus antigen testing.
So let me start with just a quick kind of overview of the different kinds of tests. And so I think that was one question that'll frame it well. So, so COVID is a virus, and virus is just nuclear material at its heart. But when it makes copies of itself and kind of can spread, it creates different kind of proteins and creates different things that we can test with different tests. It's kind of a long answer, but the bottom line is our most sensitive tests, the best tests we have, are looking for the nucleic acid. And those are the ones that are done in big central laboratories, and those are the ones done where someone is specifically collecting it in a very regulated, careful way. And so those are the ones that are the most reliable. And for that reason, a lot of places only accept those. So at medical center, for instance, at UCSF, when we're screening, we have to use that because the consequence of missing an infection in the setting of a hospital is really important. And a lot of different departments of public health and school systems are choosing to rely on that more sensitive test. And I think that is ultimately a choice of a system. And every time they make that choice, they have to decide the pro of it takes a lot more work to get it, but it's more reliable. So that's the story on the PCR test. I know I don't have all half hour to answer this question, so I'll wrap it up quickly. The other are the antigen tests, and some tests you can get in the store. I am so glad that these are available. I wish we had these the whole time for this pandemic. I think it can do a lot to relieve anxiety. And I do think they have a role in certain settings that schools use them in. Some schools will use them for screening. Some schools will use them for a first step if you have symptoms ahead of the PCR, as you've said. But I think they have to be built in very cautiously into those algorithms because unfortunately, they're very good, but they're not as good. And so places that want to be more cautious can't use them. You get both false positives and false negatives when they're used in different contexts. So unfortunately, the answer about when they use is you have to just follow the guideline of whatever system and school is using them, because a lot of decisions and a lot of stuff goes into deciding how that's built into that algorithm. And it's not enough, like you can't presume that they're just as good as the PCR tests in all settings.
Thank you, Dr. Ruel. The next question is for Dr. Woolridge. Can you address the need to balance COVID prevention measures like outdoor eating with the need to keep students inside at lunch on days with poor air quality, and share any ideas or thoughts or protocols on how to manage this or how you're thinking about this?
Absolutely. This is a question that we've talked about ad nauseum with the district as they come to us with questions about how best to implement it. They are following the SFDPH guidelines, which are informed by California's guidelines. And given that there are about 135 schools in the city and county of San Francisco, they are very diverse. As high as their number, they operate within different geographical landscapes. Microclimates are indeed a real thing here. And what does that mean? It means that it may be easier at one child's school to do outdoor seating for lunch than at another child's school. And so they're just trying to balance that as best they can in areas or in schools where it's not as easy to do outdoor lunch times. One of the things that we are doing is just trying to minimize the amount of time during the lunch period. Kids are masked, particularly when they're not eating and not drinking, and making sure that when they are not doing either of those, the mask is worn appropriately. I always use this when I want to tell people how to wear a mask, because I see too many people showing their noses when they're masking. Additionally, with poor air quality, this is an excellent question because I know it can be hard to remember, but if we remember back before COVID, when air quality was poor because fire season is becoming an annual thing and even more troubling, N95 masks have been used. And I'm not saying school districts are going to be just dishing those out. I'm actually saying that to parents, if you are concerned about the air quality, because I cannot stop anyone from looking up the data and interpreting it the way they will, you can definitely pass that message along to your kids that if you want them to continue masking outdoors with an N95 during a day where you're concerned about the air quality, that is completely fine. That is not a part of the guidelines, and so it will not be mandated, but that is something that you yourself can do.
Right.
I'll answer those.
Thanks so much. Dr. Bardach, there are a lot of questions around asymptomatic screening testing in schools specifically. And so two-part question, sort of both regarding that. What's the evidence that supports recommendations for widespread asymptomatic screening, particularly in the older group of adolescents who hopefully are vaccinated? And what's your best suggestion for testing? So what's a high rate that would then require or be your recommendation for kicking in such a surveillance system?
Mm-hmm. Yeah, both important questions. So just to clarify, thank you for asking. The first piece is the testing recommendation is generally for unvaccinated rather than vaccinated folks. And that's for the ongoing testing, on a regular cadence. LA DPH is actually recommending doing it for vaccinated as well as unvaccinated, but generally speaking, the reason why the general guidance, well, I'll finish this sentence and then I'll go back to LA. The reason why the general guidance says that it's okay to do unvaccinated only is because vaccinated people, they're less likely to get it in general. So the chance of them having what's called a false positive test is higher. And a false positive test, it can happen with any test in the world. And it also happens sometimes with COVID tests. And it can lead to somebody being identified as having COVID when they actually don't have COVID. And that can lead, as you guys can all imagine, to a ripple effect that then, other people around them are then asked to stay out of school or at doing a modified quarantine, et cetera. So that's why the general recommendation is test the unvaccinated folks, who are the ones who are more likely to get it. And then the reason LA is doing it slightly differently, they just have very high rates. And if you remember in the winter, they had extraordinarily high rates. And so they just are being a little bit more conservative in their approach. And that is completely acceptable. The California guidance is a baseline. It provides a floor of safety. And sometimes local public health officers will choose to do something a little bit more rigorous or more strict. And then the sort of other piece that was the ask is asking about sort of what's the evidence behind it. And the evidence essentially is that we know that it is a way of identifying cases before they come into campus. And we know that if we're not, like, it will then decrease the risk of on-campus transmission happening. And so that's the rationale behind doing it in general. And we do know that the older kids tend to be a little bit more likely to transmit than the younger kids. So it's actually it's particularly good to do in the older kids. And you can keep the vaccinated ones off to the side and not have them participate. And the last thing you asked me was oh shoot, what was the last thing you asked me?
Is there like a threshold?
Right, threshold, yes, case rates. So the CDC has case rates available still. So if you guys remember, we used to have county level case rates all over, that we were following for the blueprint that got retired in June. The CDC actually still has those posted. There is no great scientific consensus on, like, if your community case rate is XYZ, then you should definitely consider doing testing. But there is a general sense of, the higher it is, probably the more you want to be considering doing your screening testing. So what we're seeing right now, when we're in a surge, it makes sense to consider doing it because you can decrease your chance of having outbreaks. If you're seeing cases on your campus a fair amount because people are showing up as symptomatic, 40% of people are going to be symptomatic, even though there are people who are asymptomatic. There's 40% of kids can be symptomatic. So you're going to see your cases. If you feel like there's a lot going on, then a screening program totally makes sense. So there's no precise number that anybody is citing, but it's a little bit of a common sense approach, and working with your local public health department can also help determine that.
Thank you, Dr. Bardach. We've had so many questions, and many are on the variation of this theme that I'm going to ask each of you to comment on briefly. Given what we know about the Delta variant and its transmissibility, and the data to date around schools being open, and again, we only in some cases have a week or two, and at most 3 weeks, I'd love each of you to opine whether you believe that schools can still remain safely open to in-person learning. And if you think yes, what are the key things that we should all be focusing on as a community to help facilitate this? I'll start with you, Dr. Ruel.
So I do think we can keep schools open. I think it should be a priority. I will give the caveat to that I think to keep schools open is not going to mean keeping them entirely COVID-free. I think, Delta is transmissible. There are always going to be kind of breaks in our multiple layers of protection. But I think if we can both identify and contain those, but keep up, again, on multiple layers of protection, we can keep the rest of the schools open and get the kids back into school as quickly as possible. So I think it's really important that we anchor around this idea of what are we doing to keep them open, not kind of going for zero as our only acceptable thing. So I want to just close with what do I think we need to do? I think the focus needs to be almost a little less on the school and more on the home. We have to remember all the cases are originating from the community and usually the homes in the first place. So for this to be a success, my main emphasis is I think families need to really follow these guidelines about keeping kids with symptoms home, getting people tested, and not just dismissing stuff because that's how these cases kind of break through and get in.
I can jump in after that, Dr. Ruel. Thank you so much. I think it's super important, again, to highlight what was just said in that we all have full intention on keeping schools open because we've found during this in closing schools or that it has devastating impacts upon actually the well-being of children. And it's one of those things where we are definitely balancing that while also being just shrouded by a pandemic. And so to Tidrell's point, again, how we get through this is we have to do it together and it's all about collaborating with one another. And so if you know others in your family who are eligible to get vaccinated and are not vaccinated, then please have that conversation with them about making sure they can get vaccinated. Another thing is, just as we talked about the layers of protection, allowing for more ventilation, and ventilation, if you want to think about it in terms of a overly simplistic way, is just how much, back and forth we have between just air coming into and out of buildings. So access to the outside, because that's the ultimate in ventilation. Masking works most effectively when it is done effectively. And that means nose and mouth. And that means also too, making sure that it completely is worn comfortably and covers your child's nose and mouth, not just the mouth. COVID, we look for it in the nose, and that's because it can get in the nose. And so I really want to make sure we're doing that. And we also want to make sure that those masks do not have a lot of air traffic, particularly coming in and out of the mask. Openings, that's the concerning thing. So again, these things can be done. And like Dr. Ruel also said, we're not expecting for COVID cases to be zero in schools. But what we are trying to do is make things as safe as possible so that we can prevent what Dr. Bardach mentioned, and that's in-school transmission. And another quick note on the vaccination thing, while kids cannot be vaccinated against COVID right now, they can be vaccinated towards the flu, which is another respiratory virus that can all make us concerned for the health of children, just like COVID. So please get your kids vaccinated from the pediatricians here.
Amen. And I'll just finish off with vaccinate. Yes, I think it can be done safely. Vaccinate. Mask, stay home when sick, ventilation, hand hygiene, and then testing when if we can do it, doing that screening testing are all key things that help us, and ventilation, if I didn't already mention that. Those are the key layers. And the last thing I like to encourage people to do is it's a parent empowerment. Parents should feel free to be able to feel like they can ask about the safety plan at their schools, and that they actually also then partner with their kids. They tell their kids, this is what school is going to look like. Why do we do masking? We do masking because it keeps us safe and it keeps other people safe, right? So really helping to also wrap around your kids to bring them into the effort. They like to participate, they like to support. So encouraging people to do that as well.
Thank you so much. Thank you to our panelists. Thank you to all of you who participated. We obviously have a lot more to talk about. We have athletics. We have more asymptomatic surveillance testing to talk about. We have the appropriate way to wear a mask. We have a lot of things to talk about that we hope we'll have the opportunity to do in the coming weeks and months as we continue to partner with you all to give our kids the best educational experiences they can have. So I'll refer you to our website, coronavirus.ucsf.edu/cares. Again, just thank you. We know there are a lot of concerns in the community, and we're going to keep trying to answer these questions and provide you with the information that we have. So thanks so much, and we look forward to talking to you again soon.